Hi, Wendy, and
Yeah.
welcome to today's article review. I think it's going to be a good start to the whole review process that you've mentioned previously. And to start off this discussion, we're busy with ulnar variance, and you've been talking about that on the Instagram Live. So today's topic is the effect of axial loading on ulnar variance. Now, this is a pretty interesting study from 2018, what was done by Dr. Ozer, and he's at the Department of Orthopedic Surgery at the University of Michigan. And I think if you can take us through some of the key points of the study, what they looked at, what they found, and what the implication of these things are, that would be great.
All right. So it's super good to see some of these studies. Love that people are paying attention to this. And Dr. Ozer certainly comes to the plate with a lot of experience. And he's just one of kind of our country's specialists that spent his career working on this. So really love to see his work, and we'd like to see more of it. This is a study on axial loading and ulnar variance, and it's perfect for the topic of this week. So what we know is that when you rotate your wrist, it changes your ulnar variance. And we know here at WristWidget that ulnar variance changes with weight bearing because we've studied it for so long. But to see that forearm rotation study with ulnar variance in a controlled manner is really nice.
Yeah.
All right. So, people are making decisions on surgical techniques based on ulnar variance. So we should know as much as we can about the dynamics. Specifically, this one states very clearly that change in ulnar variance during axial loading has not been investigated previously.
Yeah, that's a very important to highlight. This is the first time that they look at this dynamic changes in ulnar variance when you go undergo axial loading.
With an X-ray, so we can see with an X-ray what's going on. Love this stuff. Okay, so they did a small study, 21 people that are normal and don't have any history of any sort of wrist injury, and then 24 people with one-sided ulnar wrist pain. So they go through an X-ray, and the X-ray is a pretty nice down below. They did an MRI, and they measured pain and flexibility, and as the ulnar variance changes, they had an MRI arthrogram as well. So, all right, we had the load is 18 kilograms or 40 pounds. I like seeing that because, as you know, we've said this before, 45 is functional. So asking them to push on a functional load is a good idea. Okay, they compared both sides, and no change with age. Although we do see load bearing tolerance goes down with age. We do see that. Okay. All right. What it says here after they did this study is that compared with the other side, there's more than 1 millimeter increase in ulnar variance is suggestive of a TFCC pathology.
Okay, so let's dig into I would say the introduction, and they have a nice picture here, and that's what you've spoken about. They standardize it. They use an analog scale. We know that they use 18.1 kgs of load as their standard of measurement. And take us through the process. What view did they use there, and what would it be for participants?
Well, okay, so a couple of things I'm surprised about is that they didn't do a neutral, because we know that pronation increases ulnar variance, so especially in men. So they did it in a pronated position, and they didn't do it in a weight bearing where we do, but I'm actually happy about that. You get a better view of the wrist in this position. This is an easy position. It's posterior, anterior. It's pronated. It's controlled. The elbow here, it mentions it's a neutral, but the elbow, controlling the elbow is kind of important. And I wonder about the influence of the elbow position in this particular X-ray, but this is pretty nice. Pretty nice. I love how they're using an analog scale.
Yeah.
Okay.
All right. And you mentioned, and how many volunteers they use. So obviously they followed a control group with a affected group. So we're looking at 21 volunteers who were in the control group and 24 who were in the other group. More or less, what were the comparison? What were they looking at?
Okay, so the age group is the same as what we've looked at, which is 18 to 65. They had more women than men, but that's okay.
Yeah.
They were doing both risks, which is really good. They were being anybody that had a risk fracture or tossed out of the study, which is great. And they did an MRI and they used a T3, which is fantastic. They also blinded the radiologist, which is great. So the radiologist didn't have any information about the patients and what their history was and if they had any pain or anything like that. So that's good. The patient was asked to hold 18 kilogram of load while the X-ray. And this is hard to do if, and they demonstrated that in a couple of cases where the patient had pain. And I think that if you're instructed to push down at 18 and you start having severe pain at 9, you're not going to really be pushing down all the way to 18 to get a really good spreading. And as we know, if the TFCC is disrupted, you're going to get spreading between the radius and the ulna, and that is going to be seen more with load. So the more you push down, the more they spread, and that's what causes the pain. Okay, here. This is about the radiologist being the way that they're measuring ulnar variance is they're doing a perpendicular longitudinal lines, which is standardized that. They measure them all the same. That's great. And they measured range of motion, and everybody in the group had normal range of motion. So that's good.
And in terms of, so we all know that they've standardized the measurements and they take a look at the two groups. So let's see what among the results they found, right? So they were testing the ulnar variance. They had them do the load bearing test in that position. What was there from the study? Was there any significant differences that we would need to take note of in that group? Was there a couple of outliers? What happened in the group?
Yeah, so in the control group, there weren't that many outliers. What they found is that ulnar variance between the dominant and non-dominant are all the same. And that there's no statistically significant difference between the ulnar variance in the normal group. They did have some outliers in the injured group, as you would expect. And those outliers, let's go down, let's go to the, so here we go. It says here, ulnar variance difference between the two sides, and noted figure 2, and noted that the majority of patients have healthy that had equal or less than 1 millimeter difference between the two sides. So on average, there's no difference between the two groups. So that's good. In the other group, there was that wasn't the case. So on the MRIs, down off of the results on the left, down the bottom. Okay, the imaging study also conducted on patients with ulnar-sided wrist pain. No relationships between ulnar variance and the type of pathology. This gets a little tricky. So if you look at this, if you look at okay, so the group 1 of volunteers and the group 2 are the patients. The patients are the ones that have ulnar-sided wrist pain. The ulnar variance in the volunteers, if you look at them, there's no load, axial load, no dominant, non-dominant. There's not a significant difference between those two. The ulnar variance difference is very small, and it's 0.45. So I want to accentuate in a minute how difficult it is to be working in these small numbers and the variabilities of these small numbers. And this is over 21 people, and the variance is just 0.5 millimeter. So we're talking about 0.5 millimeter over that. Now, when they do the group 2, the patients, and they've got 24 patients in this, and they mentioned in the study, there are a couple of cases that had severe pain with the load, and they couldn't do the loading. Those variants are going to be bigger versus some that maybe be a mild case. And so the difference here is just a little short of 1 millimeter. And so we're talking about a 0.35 difference between the ulnar variance changes in the normal people and the people that have. And that's, it's hard to extrapolate a lot of information from that small number.
Yeah.
Yeah. So this graph here is important too. So there's a lot of outliers in this, and there's not a lot of symmetry in this graph or trends. And that's good to know.
Yeah, so we're getting to the part where they show the images, right? And that's what you mentioned is in terms of the millimeter difference. So what does it actually look like? What does a 0.3 or 1 millimeter difference look like on X-ray?
Okay, so this is first one is a normal case, patient A, I guess, and a volunteer. And you can see how clear the edges of the ulna and the radius are, and how the line that's drawn, the yellow line that's drawn, how hard it is to draw that line reliably. It's a shadowy, kind of cloudy line, and you're supposed to draw the tip of the ulna and the radius. And so in this case, it's pretty easy that it's just a clenched wrist, that it's no difference between right and left.
Yeah.
Pretty easy interpretation. Now we're going to go down. We're going to see something. This one is the right and the left, without a load.
Yeah, that's a 0 kgs. Yeah.
Yeah, it shows it looks like there's something going on here. And you don't, there's something going on at rest. Just with a quick punch, this is no load.
Yeah.
Something significantly something going on at rest.
Yeah.
To the tune of 1 millimeter. We don't really know what the position of the elbow is in this point. We don't know if there's any pain at this point. But what we do know is when you put a load on it, on the left, you get a 2.3 millimeter change.
Yeah.
But more importantly, and I think this is often ignored, is there is a spreading between the distal radius and the ulna right down the center. And this is really, this spreading of the radius and the ulna is visualized really nicely here.
Yeah.
It's that spreading. In this patient, it's young, got a beautiful definition on the edges of the bone. Super easy to define the edges of the bone. It's a young case. That's a little harder to do as we get older, or if there's arthritic changes in the joint. What this person we also know has a 6-month history following a fall.
Yeah.
And so it's highly likely on this first view that ulnar variance that we're seeing there without a load is a significant tear of the TFCC. The TFCC is holding that ulna and radius together.
Yeah.
And you can see the first thought is, okay, it's not holding it together. So you're going to see an ulnar variance.
Yeah.
You're going to see more of it when you load it. So when you add this 40-pound load, which is just a functional load, look at the widening between the radius and the ulna.
Yeah.
That widening that is contributing to this huge ulnar variance. If you were to take this wrist and squeeze it externally with the wrist with it, I bet you anything the ulnar variance would be the same.
Yeah, especially as they showed, right, that the magnetic resonance arthrogram indicated that this particular case had a detachment of the TFCC on the radial side. So that it goes with what you're saying.
Yes.
Yeah.
Yeah. This is a really clear view of the challenges of making decisions. Now, if let's just theoretically say that this person needs to have a surgical procedure.
Yeah.
I wonder if just cutting that ulna is going to solve the problem. Just cutting the ulna off is not it's not going to. It's just going to show that the variance is gone. I don't think it's going to bring back stability.
Yeah. Yeah, and
Here.
would you say that is due to that TFCC detachment? So obviously, being the primary stabilizer at the distal radial ulnar joint, not having that in place, would you still expect some spreading to occur?
Yeah, if the TFCC is involved, there's spreading at the wrist that's accentuated with load. Now, if you cut off the ulna, the part of the ulnar head, you've still got the spreading, but you do have the benefit of I think, very strong inflammatory reaction, which probably helps stabilize that just a little bit. Not really well known, but it's these. What I love about this is there's a lot of missing information, but what I love about this is that it shows an ulnar variance. It shows a significant change in ulnar variance with load. A real big change. Like you go back up and you see on the right 0.8, on the left 0, and then go down, and then you see 0 and then 2.3.
Yeah.
And so the 2.3 is significant. That's a significant tear. Now, what would be lovely is to take this person and whatever procedure was administered, do another loaded test, and follow that change.
Yeah. They had another case. Obviously, we saw that case A now, and this is where I know you mentioned you would like to see if there was pain or not. And actually, one of the cases that they reported, they did the same thing, but they had an indication where there was pain on the right wrist at 9 kgs. So how does this differ what you see? Take us through this specific case.
Okay, so we've got this one case that's on the first view. It's got a right and a left, no load.
Yeah.
And so on the right side is the one that is causing ulnar-sided wrist pain. So the left is normal. Now this is a little bit of an older patient. You can see how the edges of the radius are a little bit blurrier, but not much. So you got a 0 ulnar variance on the left. On the right, you can see how hard it is on the right to draw that dotted line. So there, if you look in the center between those two bones, you see, just take notice of that. Okay, so then this patient loads it and is unable, based on pain, to load it beyond 9 kilograms.
Yeah.
So if you look, scroll it just a little bit down so they can compare, just in the view, Jen, from the top one and the bottom one, so you can see. There we go, right there. Okay, so you can see an increase in gapping between the radius and ulna from the top left and the bottom left. Well, it's right hand, but it's a left picture. You can see there's a spreading, but we're not getting a full load. So if this particular person on the right wrist were to actually do an 18 kilogram load, you would probably see a much bigger ulnar variance and a much wider gapping between the radius and the ulna.
Yeah.
On the left, there's a little gapping too. So I wonder if this patient is got something going on bilaterally. Now go down and you'll see that this was an insidious onset. This wasn't a fall.
Yeah.
And so it's possible that this is something bilaterally going on, but we don't know.
Yeah.
And what's interesting is that this person had more pain at a lower load and not as big of an ulnar variance as the other one did.
Yeah. Yeah.
You really do see more ulnar variance with more load. But you can't generate that true picture if it's painful. So it makes the data difficult to interpret.
Yeah, and would you say, obviously they noted that on her right wrist, she also had that central tear of the TFCC, right, based on her MRI results. Is that what you would expect, seeing that 9 kg tolerance of pain? So she has less ability to bear load in that axial position. Is that similar to what you would expect to find with a central TFCC tear?
Yeah, and depending on how bad the central tear is, you know,
Yeah,
if it's this looks like a moderate to you know, it's 9 kg. That's a severe tear,
yeah,
and you do see a change in the ulnar variance on the right versus the left.
yeah,
So I would expect to see a change in ulnar variance relative to load.
yeah, yeah.
Central tear. Yeah.
Okay.
The question yet still
Yeah,
is it the ulnar variance that causes the problem, or is it the tear that causes the ulnar variance?
yeah.
And
Well,
until if you can't see the ulnar variance until there's a load,
yeah,
then you're not going to be able to measure that. You need to know first, A, is what is the standard deviation of ulnar variance with load in the normal population under X-ray.
yeah,
Get that first, and then do a weight-bearing test to put people in groups. So you
yeah,
look at ulnar variance in mild tears, you look at ulnar variance in moderate tears, or, you know, and then severe tears. And those defined by weight-bearing tolerance.
yeah.
That's how I would design this study.
Yeah, ideally, that would be a good study to run. And obviously now, you know, you went through the study and you gave us a bit of a summary of what they did and what they looked at. What was their findings? So what is the relevance of this? You know,
Well,
taking a look at ulnar variance.
this is a big deal. Ulnar variance increases with load.
Yeah,
Yeah. So axial load increases ulnar variance.
all
So
right.
when you load the wrist, there's a spreading between the radius and the
Yeah,
ulna. All of us.
yeah,
It's not a very big spread if your wrist TFCC tear is normal. Your TFCC is normal.
yeah,
It increases, ulnar variance increases when there is a TFCC tear with load.
yeah, yeah,
Yep. So what it says is that if there's more than a 1 millimeter change between the two sides in ulnar variance or severe pain with axial loading, then their TFCC pathology is likely.
yeah. And like you mentioned, you know, you would need to have a further study, and like you mentioned previously, is having a standard of what is the normal deviation in a uninjured or healthy population. How does ulnar variance change under load?
Yeah.
And that's what they also mentioned. You know, that's required to really say, well, what is that causal relationship between ulnar variance and pathology? And what do we know? We need to know a baseline of data. And I think that's what you
Yeah.
mentioned beautifully. Yeah.
Yeah, I love this study. I think this is a great start, and all
Yeah.
research that's published has value. This one has value too, and it
Yeah.
should inspire further investigation of this measuring load with on X-ray to look at ulnar variance. Yeah, I think ulnar variance is I don't think it's a great way to define pathology in the wrist.
Yeah.
I've said this before. I think that once we find the normal range of adults, 18 to 65, the normal variability of ulnar variance between right and left and
Yeah.
age and height and all of that, we're going to find that that range is actually kind of high.
Yeah.
And really what I'd like is a further investigation of the variations of ulnar variance in the adult population under load.
Yeah. Yeah.
That
I
would
think
be
that's a key takeaway, right? It's further investigation. We
Yes.
always need some further investigation to
This
help
is
better
fantastic.
yeah.
And I love that they're using an analog scale.
Yeah, I also thought that would be right up your alley. Another researcher, you know, interested in the analog scale and its
Yes.
usability, being such an accessible and cost effective. You know, as they mentioned, it's so easy
Yeah.
to use, and
Yeah.
I mean it's just a nice tool to have.
Yes.
But that's great. I think for today, Wendy, we really appreciate that you took the time to go over this article with us,
Yes.
and you know, just break it down and give a bit of a summary of what they did, what it means, and you know, what can we take home from this study. So I think everyone would appreciate that you did this today, and we look forward
we'll do
to
more.
yeah, we'll look forward to a couple of more reviews as we start to delve deep in the ulnar-sided wrist pain research and what does it mean outside of the research? What does it mean for the everyday person, and what does it mean in practice?
Yes.
So we're looking forward to it.
Yeah. Thank you, Jan, for your time. We'll see you soon.